Fantastic. Well, good evening, everyone. My name is William Becknell, and I pray that all your weekends have gone well so far. I want to thank you for taking this time out to join the Brothers of Tulsa Alumni chapter of Kappa Alpha Psi fraternity for our first of many awareness summits. Thank you also to our pole marquee Juan Colbert for his leadership and vision of the chapter within the chapter to bring you all worthwhile and beneficial information. This month's focus is on kidney health, and our speaker for the evening is our own brother, Dr. Malcolm L. Buford Jr., MD. A brief background on Dr. Buford. He's a Tulsa native. As a Tulsa native, Dr. Buford attended the University of Oklahoma for his undergraduate degree in chemistry. He then attended OU's College of Medicine and completed his residency, junior year, and fellowship at KU Medical Center in Kansas City. He then entered private practice in Washington State until professorship, at OU back in Tulsa. Dr. Buford has received numerous awards, headed many departments, and is recognized as a leader in the medical community. He believes that patients, communities, and providers must all ascend together as we move forward in our ever-evolving field of healthcare to the benefit of all involved. Again, my name is William Becknell. I will serve as your moderator, and I promise to keep us on time and end at or before 7 p.m. to remain respectful of your time. If you have any questions, please send me a direct message, and I will make sure that we address it during our Q&A session at the end. If for any reason we do not get to your question because of time, I invite you to send us an email at KAPsi Tulsa Alumni @gmail.com. Again, that address is KAPsi Tulsa Alumni @gmail.com, and someone will respond to you. Thank you very much. And without further delay, I'd like to introduce you to Dr. Buford.
Okay. So I first wanted to put out a disclaimer that any of the pictures or images that are in this discussion, as well as all of the data sets and tables, are not my own. They do not belong to Kappa Alpha Psi, and we are not also responsible for any changes or updates to material and the evolution of understanding of disease. Kidney disease is fairly prevalent worldwide in the United States, and many people, when they talk about kidney injury, have a hard time conceptualizing exactly what that means. So I wanted to start off relatively simple and then kind of make it a little more complicated, but not too much. So we're going to cover the five common issues: what, where, when, and how, as well as why. Just briefly, the earliest form of medicine really was dermatology. So the cutaneous or the skin manifestation of problems that are going on inside of the body were noted even back in the Egyptian era and are documented well and preserved on papyri. However, the second most ancient form of medicine was nephrology. And at that time, it was really known that if you looked in the urine, you might be able to discern some ailments that were happening for people as they brought their condition to your awareness. At the time, we called it uromancy or uroscopy, essentially looking into the urine for disease processes. And this is well documented at the time of Hippocrates. As it evolved, a profession was born. And it was actually fairly common, particularly in the 13th to 16th century in Europe and the UK, to have what are called piss prophets. So the idea or the term having a pot to piss in was not a vulgarity. There were actually glass containers or bladders called matula, and one would urinate in this container and bring it over to a physician, or even at that time, unlike an era where there wasn't an awful lot of equality and opportunity and employment, women, so-called wise women, would take these urine samples, hold them up to the light, put them on a ledge where the sun could hit them, and essentially divine what was going on with people's health. Around 1550, Thomas Linacre, who was a British physician and actually the person who established the Royal College of Physicians in London, essentially wrote a treatise outlining this practice because there wasn't an awful lot of information or validity, reproducibility to their findings. But even as of 1637, there's a book, and I actually have a copy. One of my partners in Washington gave me a copy of this book called The Piss Prophet, and it was a satirical commentary on how this practice was still being used and how archaic it was. So, you'd figure that in 2022 and slightly before, we had evolved quite a bit. And it's kind of true because they even had books where you would take these Utula and look at the different texture, the smell, and even the taste of urine to determine what was going on with someone's health. To some degree, we've evolved, but we still actually look at the urine and at the pigment and at the color of urine and see if we can determine people's disease. However, of course, we do not taste at this time. So what is nephrology? Nephrology is the study of the functional unit of the kidney. In each kidney, there are about 1 million filters, and it takes quite a bit of time to get an appreciation for what they do. So nephrologists are internal medicine physicians that have done further training into the field of nephrology to try and assist patients with their health concerns in the spectrum of order of diseases. And I word this carefully because not everybody who has kidney disease needs dialysis. Not everybody who has kidney disease has impending failure of the organ, but sometimes in the spectrum of kidney diseases, you need to see a specialist. There are also subspecialties, or what we call subfellowships, special interests in interventional nephrology, transplantation, and then dialysis theory. And then, of course, there are some triple boarded subspecialties that are kind of becoming popular, where someone may have internal medicine as a background and do either pulmonary critical care or cardiology plus nephrology. And there's a big push actually to try to get people triple and quadruple boarded. So an example of someone quadruple boarded would be a medicine pediatric physician who did cardiology and pulmonary, or cardiology and nephrology. So in the field of nephrology, we're not an island. There's quite a bit of overlap in other subspecialties. So you have cardiology and endocrine, urology and rheum. And so endocrinology being the specialty that deals with hormones, in particular, that's the specialty that diabetes mainly would be dealt with. Rheumatology is things like lupus or rheumatoid arthritis or osteoarthritis. Urology, clearly problems with the plumbing, but there's some overlaps. So for our purposes, we see an awful lot of electrolyte abnormalities in nephrology and also in endocrine. There's blood pressure that's not just a cardiology issue; it's mainly a nephrology topic. And then chemotherapeutics when it comes to transplantation or for the treating of lupus, which affects kidney disease. We also have specific situations where we have a kind of a triple overlap, where an endocrinologist may be seeing someone with us who has a congenital abnormality. We are seeing them for their blood pressure, but cardiology is seeing them because they also have peripheral arterial disease, or they have refractory high blood pressure that requires intervention. So we have to work together as a team, and it takes a really good internist or primary care physician, a really good primary care, to be able to coordinate all of those subspecialists to keep them communicating with each other, and also hopefully to process that information and share it with the patient so that they are aware and up to date on what's going on with their health. So where are the kidneys? Ironically, many people don't realize that they have two. They actually don't have just one kidney. And they sort of sit in a jello mold or in somewhat of a semi-solid framework that aligns the back of the body called the retroperitoneum. that word in particular isn't all that important. Suffice it to say that the kidneys aren't just freely moving about in the body. Consequently, it is increasingly uncommon to feel pain in the kidneys unless they are actively infected or there's some other process. They're deep to other organs, meaning that they sit behind an awful lot of the free moving organs like the stomach or the spleen and under the liver. And they're encapsulated, or they're in a capsule. It's actually fairly rigid. It's pretty tough. And so the kidneys don't have an awful lot of wiggle room, as it were, when it comes to expanding. So that's one of the reasons why they may hurt when infected. On the front of them, they're lined by something called the visa peritoneum. But more importantly, on the back, they sit in what's called the transversalis fascia. That's relevant when it comes to other diseases, like if you have a hernia, because it's that same layer of skin, if you will, where if you have a puncture, then you can have something ascend to where the level of the kidney is. Inside the kidney, we have these smaller tributaries or breaking down of blood vessels. So you have blood that comes into the kidney. It takes an awful lot of arterioles and small dividing roads to get to the functional unit of the kidney, and then it comes back out to return to the rest of the body purified. So the kidneys are, for all intents and purposes, an extremely fancy filter that has some various functions. At a closer level, and this is not to be obviously looked at with any significant depth, but if you look on the left-hand side here, you'll see that there are these small collections of blood vessels. I kind of look at them as a ball of spaghetti in a bag, like a Ziploc, right? And so blood enters into these small little spaghetti balls, filters through them, and then leaves. And that's where all kind of the magic is done. So on the right-hand side of this graph, there are these tubules. And these tubules are what pushes and pulls and makes urine so that it ends up leaving at the bottom of this device. And that whole functioning unit is called the nephron. So what do they do? So, the body's a closed system. What comes in must come out, right? So the kidneys regulate total body water, and that has to deal with blood pressure control and whether or not someone has shortness of breath if they have too much fluid on board. There's the balance of electrolytes. So salt is not just sodium, but potassium, calcium salts, magnesium, and then acid base. And this is where there's a working conjunction with a relationship with the lungs. So our bodies, particularly like as we eat protein, breaks that protein down for nutrition, right? So we want to make something that builds our body up. Well, as that waste gets developed and these processes go through, you generate a significant amount of acid. And your body has to get rid of it. One way is to pee, the other way is to breathe. The fastest way the body can react is to breathe, but the system that takes the majority of that burden is in fact the kidney. The kidney, however, is not just a bag of blood vessels. It also has an awful lot of cells in there that secrete hormones, that activate other hormones and substances in the body, that get rid of other things than just water and salt, and serve as a readily available location or tool to kind of assess what else is going on in the body. So it's not unusual to have women who are gravid or who are pregnant to pee so that they can get either a pregnancy study or they can understand if they have protein or sugar in their urine. And so, the kidneys can serve also as a medium by which to test systems. We talk an awful lot about kidney disease, but we kind of want to know if someone has sudden or what we call acute, or if they have chronic kidney disease. And the majority of the focus of Kidney Month and most of the literature and research now is on the management of chronic kidney disease. And chronic kidney disease, as a very firm definition, is any abnormality of the kidney structure or function that's more than 3 months that actually can affect the kidney, that affects the health of the person. So you can have an abnormality of the kidney, let's say a kidney cyst, And that really doesn't have any significant bearing on whether or not your kidneys are going to end up failing. As a matter of fact, it's very common to develop kidney cysts, one on either side by the age of 50 and two by the age of 65. So if you are told, or someone in your family is told, hey, listen, I have a cyst on my kidney, well, that doesn't necessarily have to be a marker of pending damage. There are 5 main ways that we kind of group kidney function or dysfunction in disease. I won't go through these exhaustively, but I will say when you have an infection in the kidney, we tend to think of that as interstitial. And then there are a host of genetic abnormalities that can happen both in the body as a whole, but also in the kidneys specifically. And they can have an impact on your kidney health over time. Those are clearly more common in children, but there are some that present later in life as adults. We usually, though, lump kidney diseases into one of 2 categories, and that's primary or secondary. Most disease processes we lump into those type of things. So primary would be anything that happens in the kidney that's affecting the rest of the body, whereas secondary would be something's going on outside in the body and the kidneys are the victim. And so that's important because when it comes down to treatment, you're really going to have to treat the primary cause, right? You're not going to worry about trying to just treat symptoms. Those symptoms are important because that's usually how people have a hard time, but you really want to get to the root of what it is that's causing the problem. So how common is chronic kidney disease or kidney disease? Far more common than people know. 1 in 3 Americans has or is at risk for chronic kidney disease, and that number will be further explained. But 1 in 7 has a known and well-defined degree of chronic kidney disease. Now, just because one has chronic kidney disease does not mean that one inexorably progresses to dialysis, which is kidney replacement, or the need for transplantation. But it does mean that at different points, there may be a need to intervene. But as a whole, estimates from 8 to 16% of the world's population have some degree of chronic kidney disease. Interestingly enough, the majority of the people in the world who have chronic kidney disease are where there's the majority of the people of the world. And so, or at least where it is measured. And so China and India have the lion's share of chronic kidney disease and burden when it comes to the world health system. But for our intents and purposes, we're going to be somewhat jingoistic and focus on the United States. But again, if we look at certain pieces of data worldwide, in 2017, it caused a significant loss of life, 1.2 million people. If you lump into that the number of people who died with chronic kidney disease on record, who also had coronary vascular disease or cardiovascular disease, 1.4 million. In totality, we're looking at 5% of the world population that died in 17 almost, where they had some degree of cardiovascular disease and chronic kidney disease. And unfortunately, the two are really inextricably intertwined. And you can't get away from the impact that chronic kidney disease and its accompanying problems yields on the cardiovascular system. But unfortunately, it has progressed to being from the 17th in 1990 to the 12th leading cause of mortality. Now, to put that into perspective, and this is in 2017, not 2020 or 2022 data, but in 2000, to put that into perspective, chronic kidney disease took more lives in 2017 than tuberculosis and HIV combined. Somewhat more disturbing is the fact that it was second. The one that it was right next to was motor vehicle accidents or loss of life through vehicles. So that's clearly still a problem, but tuberculosis and HIV do not necessarily or do not statistically take as much life or do not provide as much burden as chronic kidney disease on the world stage. So how do we rank or stratify chronic kidney disease? We do that essentially by measuring how well the kidneys get rid of stuff. And there is a protein or a muscle breakdown byproduct called creatinine that we measure. And we tend to stratify kidney disease in one of 5 categories. And so we look at how well the kidneys are getting rid of creatinine, and anything that's greater than 90 mils per minute per meter squared, but I tend to tell patients to look at it as miles per hour because everybody can pretty much identify with miles per hour. Anything that's greater than 90 miles per hour is okay, or it's fine. It's when you get less than that that's a problem. And so you can kind of think of it grouping from 90 to 60, 60 to 30, 30 to 15, and 15 and below. At each one of those stages, regardless of whether or not someone is aware of their degree of kidney disease, there are some changes that happen in the body physiologically that as physicians we need to be aware of and we need to be treating and watching for. There has been a big push in medical literature to get away from body surface area adjustment. That's that 1.73 meters squared, because it is somewhat archaic, but the problem is that it's easily reproducible. And then racial and gender adjustments have been made over time. Thankfully, the most recent equation and estimation that we use called the Chronic Kidney Disease Epidemiology Effort or Collaboration, the CKD-EP from 2021, that actually takes many of those things into account and gives us a great way to approximate and to follow this data, meaning that people don't have to have as much of a burden in trying to figure out what's going on with their health as they used to. Another way that we adjust this is looking at protein in the urine, so-called albumin. You can kind of think of albumin as egg white. And when there is egg white present in the urine, it tends to influence prognosis or influence the trend toward increasing damage. So if the physician says, hey, listen, I need you to check your urine, let's do a dipstick, and let's see whether or not you have protein in your pee, this is the reason why they're looking for that. Because even if you have normal measuring kidney function, if you have a significant amount of protein in the urine, over time, that will lend to scar and damage. And that spillover is not just albumin, but it is also other types of proteins, from vitamins to coagulation factors, things that help your blood clot. So you can imagine that if you don't really want clots happening in your kidneys, and then immunoglobulins, which are the proteins that are made to help us fight infection. So we are mindful of the fact that there's a difference, but when it comes to just routine screening, when your doctor says you have protein in your urine, that's a red flag. That's something to pay attention to and to ask, okay, well, how much and for how long and how do we treat it? And again, this reinforces that concept. So the reason why we take protein into account is because for every 4-fold increase in protein in the urine, there is a 300% increase in risk of needing dialysis or transplant. Conversely, for every 4-fold decrease, you have a 34% less likelihood of developing end-stage renal disease. So the hazard ratio, or the likelihood of it happening if you have a decrease, is an awful lot lower. High protein in the urine contributes to many problems aside from bubbles in the pee. It also contributes to an elevation of your cholesterol. It contributes to advancing coronary heart disease or cardiovascular disease, and it can have a bearing on nutrition status as well as your vitamin balance. So it can have many different effects in the body. This picture here is actually a picture of what's called a lipoid cast or fatty cast in the urine. So we actually do still look at pee. We just tend to use microscopes and polarized light, like in this picture. And these droplets here, which is what they are, these Maltese crosses, they're actually lipid droplets of protein that's made it into the urine and cause some fat loss. So when we take a urine sample as a nephrologist into the side lab, usually associated with the clinic, we can spin the urine and then look at it under the microscope, put on some polarized light and tell you whether or not you have a significant amount of protein in your urine without you having to have a biopsy or something like that. So what did the tables tell us? So what they do say is it gives us a framework for discussion. It allows people to have a readily available visual representation of severity. And unfortunately, or fortunately, it impacts healthcare policy. So what it doesn't tell us necessarily is prognosis. So just because someone has chronic kidney disease stage 2 doesn't mean that they have dialysis in 2 weeks. Just because somebody has chronic kidney disease stage 5 doesn't mean that they are going to stay at stage 5. It also does not tell us what the cause is, nor does it obligate someone to a particular strategy of treatment or initiation. So just because someone says, your primary care doctor or your nephrologist says, hey, listen, you have chronic kidney disease stage 3B, it doesn't mean that you need to have dialysis. It doesn't mean that you need to consider transplantation at that moment. But hopefully it will be explained and you'll have an opportunity to reference and to gauge the severity of involvement of a process so that you can make the most intelligent decision possible. So what are some of the signs of chronic kidney disease? So the main one that people think about is, oh my goodness, if I have chronic kidney disease, I'm going to stop peeing. And that couldn't be further from the truth. So if you look, I have nocturia with an asterisk. Well, nocturia simply means peeing at night, okay? One of the, I guess I'd say, opposite expectations that people have is that if your kidneys are failing, that you'll have lesser urine output. And in reality, as the kidneys fail, people tend to pee more. And they tend to pee more because the kidneys concentrate urine. While as they fail, they still have the same amount of waste to get rid of. And so they have to put it in more urine because they can't concentrate it. And so you pee more. Weakness and fatigue, nausea, particularly at the smell of cooking meats. So people tend to get protein aversion. That's a fairly late finding. But the smell of cooking meat, if you used to love the smell of bacon in the morning, and now you run outside because you can't stand it, you need to see your doc. Edema. Edema is the deposition of fluid in tissue that's not supposed to be there. That tends to happen as kidneys can't get rid of salt, and that goes along with breathlessness. The easy bruising and gum bleeding, that happens because of platelet abnormalities. And what usually does not happen is pain in the sides or pain in the groin. That typically is not kidney related, can, but usually not. And then pneumaturia, which is increasingly rare that most people don't even know about, is where you get kind of a machine gunning from urine passing because of air. And that's a whole other issue. So common to the more common diseases, of course, diabetes and high blood pressure. We're going to touch on those briefly. The reason why the overall risk in America or worldwide of chronic kidney disease is 1 in 3 is because of diabetes. It is the #1 cause of end-stage renal disease in the United States. And it is not simply because of high blood sugar. Diabetes is a vascular disease. It is not a sugar disease. Yes, blood sugar needs to be regulated. Yes, blood sugar is very important to be tightly controlled. It has to do with an awful lot of things, but more importantly, diabetes is a disease of blood vessels. And that's actually how it manifests itself when it comes to the diseases that it causes, right? So diabetes causes neuropathy, that is small blood vessels in those nerves dying off because of the disease process. Peripheral vascular disease, higher risk of stroke and heart attack, and again, and then, of course, kidney disease. Screening for diabetes is the same with anything else. The doctor will do a urinary study, they'll do a blood test, but then they can, like I mentioned earlier, will want to check your protein in your urine to make sure that it has not gone up. The reason being is diabetes is also the most common cause of protein in the urine that is secondary as a source. So there are some disease processes that are primary that increase urine protein, but those are in the kidney. Diabetes is the most common cause outside. And then, of course, if you see foam or layered bubbles, that's also a pretty good clue of the presence of protein in the urine. There are other causes that are not bad or pathologic that can cause protein in the urine. So fellas, don't fret if you are at the urinal and you see a couple of bubbles, but if you are, so if you exercise vigorously or have a fever or stand up too quick as a young person, those are some reasons to have protein in the urine. High blood pressure, the second most common cause of kidney failure in America, with 1 in 5 having some degree of chronic kidney disease issues. What matters most in high blood pressure is how long you have it and how well controlled it's been. But you can have some relatively rare occurrences. So something called hypertensive crisis, where blood pressure shoots up suddenly from a stress or from a medication or from a lack of taking meds. And then, of course, in pregnant women, preeclampsia or eclampsia can precipitate what's called acute kidney injury, so sudden kidney damage. As that resolves, it still leaves scar. The goals for blood pressure have been debated many, many times. But what we have continuously found is that if you can get your blood pressure about 135/75 on average, you're doing pretty good. The only time when we truly advocate for lower pressure than that is if you have the presence of protein and diabetes, then there's evidence to suggest slightly lower blood pressure is better. Again, like I said, number 1 and number 2, right? So diabetes accounts for about 45% of people on dialysis. High blood pressure for about, again, 30 to 45%, and about 2 or 3/3 of all people on dialysis have high blood pressure, diabetes, or a combination of the two. Now, I want to kind of adjust that just a little bit, because when you have end-stage renal disease on dialysis, you tend to have high blood pressure. So that's a chicken and the egg moment. But we do know that regardless of the occurrence, most of the patients who are on dialysis have those two issues. We also know that there's a higher mortality with people who have diabetes and are high blood pressure, regardless of the total amount of protein in the urine. And if you overly control blood pressure too aggressively, we have something called the J-point phenomenon. That is, you actually have higher mortality if you are too aggressive at controlling blood pressure. So this is not an opportunity for extremes. This is an opportunity for moderation. So just briefly, what difference does stage make? This figure shows all-cause mortality in those 66 and older from something called the United States Renal Data System, and it lumps diabetes or coronary vascular disease or both based on stage. On the bottom is the stages. On the side is the deaths per 1,000. Now, I have to put this into perspective. This is risk. It isn't necessarily that 230 people die at stage 5. That's not it, right? But per 1,000 patient year risk, it is fairly substantial when you have diabetes and coronary vascular disease, cerebrovascular disease with progressed kidney dysfunction. To put it in a different way, and this is very, very busy, but I wanted to put this in there for 3 reasons. One, if you look at the ledger at the top left, it says diabetes type 1, type 2. Glomerulonephritis is the filters of the kidneys being inflamed. That's a primary problem. High blood pressure, and then other things. Over time, we have seen an increase in mortality and incidence of chronic kidney disease with, of course, diabetes and high blood pressure. The DALY is called disease-adjusted life years. Essentially, that means the length of time that a segment of the population has had the problem and the number of years lost due to the problem. The importance of this graph is that despite all of the advances in medicine, the key is control of the primary problem. If people can get their blood pressure and their diabetes under control, which are the 2 largest areas that have been changing, and some areas have actually decreased substantially, then chronic kidney disease can be decreased in its incidence or the likelihood of it happening. Briefly on dialysis or end-stage renal disease, which are somewhat synonymous. Almost 800,000 people in the US are living with it as of 2020. 71% of those people are on dialysis. 30% of those people have a transplant. When it comes to risk factors or the ratio between people's, because oftentimes we talk about healthcare disparity, which is real, women are less likely to develop kidney disease than men. Whites are 3 times less likely to develop end-stage renal disease than Blacks. And Hispanics tend to have worse kidney function than non-Hispanics. Now, there are some twists to this data because when people are on dialysis, it's different than when they have end-stage renal disease. When they're on dialysis, Blacks tend to live longer. Hispanics tend to as well. Women tend to live shorter than men, which is, again, not typically the ratio. So it isn't that that's an improvement at all, but I'm saying that the ratios as we see them kind of have to be taken into account or with the right perspective. This next to the last, I think, slide, the number of new cases of people who went on dialysis has increased from 199 per million in 1990 to 371 per million in 2009. But the graph I thought was most impressive because the number of transplants that have happened over that time frame have really leveled off. Now, this is all cases, all right? This is not children. Children tend to get transplanted far more readily and quicker than adults. But I do think it's very important to make note of the fact that despite the trend toward increasing incidence of end-stage renal disease and the need for dialysis, transplant really has not kicked up. So people should really discuss with their families and advocate to try to think of living donation. Again, transplant wait time, right? So adults tend to wait much longer, 46 to 59 months than children. Blacks tend to wait longer than whites, and Hispanics than non-Hispanics. From another field of view, and again, this is the disease-adjusted life years when it comes to chronic kidney disease and end-stage renal disease. Everything that is blue is better. Everything that is red is worse. And the reason why I bring this up is the disparities in healthcare are not just in America. And they aren't just focused on purely affluent nations, but there really is a trend toward increasing disease severity and years of lost life because of a lack of availability of care. I don't know if I have it. Yeah. So in 2017, about 2.5 million people needed dialysis. That's projected to increase. And again, we have a pretty high, significant, very significant incident of the need for chronic kidney disease treatment and the incidence of CKD worldwide. But about 7.1 million people, it was thought, in the 10 years prior to this last study, from 2008 to 2018, died without having renal replacement therapy. And most of those were from countries that it wasn't prevalent, not the disease process, but the availability of renal replacement. So, to be in the United States and to have access to dialysis and transplantation as even options significantly improves the survival of people in this country. So just to kind of summarize, what should people be watching for? Obviously, if you have diabetes, look at your blood sugar. If you have high blood pressure, check your pressure, check your pills. Obesity is a problem because it lends to both. Do want to decrease our salt intake as much as possible. Less than 2.4 grams is actually the recommendation, but I'll just say 2. Lead, which is usually not a problem in this country, has been in some of our northern states as of late, and that increases risk of kidney disease. Be mindful of over-the-counter medications like ibuprofen. Non-steroidals can impact kidney function as well as the utility or the function of your other meds. For instance, ibuprofen can negate the use of, the efficacy of diuretics, and excessive alcohol intake worsens all of it. So I think with that, I'll take whatever questions anyone may have.
All right, Dr. Buford, thank you very, very much for this information. Bringing it, to the community level, if you will. A little personal point here. You mentioned that 1 in 3 Americans will suffer kidney issues. I myself suffer with low creatinine levels, and I'm being monitored like every 3 months, actually by an oncologist. So thank you for bringing that home for me with more information that I'm equipped with. I know with you being a brother now, I can always call you to ask that question. Questions.
Of course.
We did have several questions.
Okay.
Do doctors automatically check for kidney problems during a routine visit?
That's a good question. Yes, every time that you go in and you have blood work that looks at your chemistry, there are 2 numbers that they're looking at also. Creatinine is one, and BUN is the other, blood urea nitrogen. Now, if I'm fair, knowing how to interpret that data, I think, is an issue. Being a subspecialist who gets referrals, one of the things that I see frequently is someone will be referred once their creatinine, let's say, is 2, okay? Normal being 0.5 to 1.5. And this is a very important point, and I hope that I say this correctly. So if someone has a creatinine of 0.5 in 2015, 0.8 in 2017, 1.2 in 2019, and then 1.6 in 2020. If I see them in 2022, I've missed the opportunity to intervene all the while, because there's been a process that's been ongoing. And regardless of whether or not that number was in the quote unquote normal range, there has been loss of functioning tissue, which has caused or been documented by that climb, right? And that is remarkably common. So people don't tend to look as much at trends. It's not a criticism. I think it's built in, it's a systems issue, right? It isn't necessarily the provider. It's a systems issue.
Understood. Okay, you all, in the interest of time, I know I told you that I would get you off by 7 p.m. No worries, Doc. We would get off by 7 p.m. However, we have 2 other questions, And if I may, I'd like to address them really briefly. Since we got started about 15 to 20 minutes late, please bear with us if that's okay. Dr. Buford, number 2 is, does chronic kidney disease impact African Americans at a higher rate? And what can we do to prevent kidney disease?
So yes, it does. Obviously, I show the ratio of the incidence of developing end-stage renal disease compared to Caucasians. We also have, interestingly enough, a genetic predisposition, and I'll touch on that in a second. What can we do to prevent chronic kidney disease? We can take care of ourselves. We have what we call epigenetic problems. Epigenetic meaning above our genes. So when it comes to celebrating, we tend to celebrate around a table. We tend to celebrate with food, right? We tend to celebrate with good food, that are high in salt and high in carbs, right? If there's not mashed potatoes and macaroni and cheese and dumplings, you know what I mean? Like those are 3 carbs. Like we need to do better than that, okay? So, but that's an issue. So culturally, epigenetically, we tend to compromise our health. Now, from a genetic perspective, similar to the mutation that we have that causes sickle cell disease, we have a mutation called the APOL1 gene in African descendants that helps to kill spirochetes, which are the corkscrew bacterium similar to syphilis, okay? This is not a Tuskegee thing. This happened from Africa. This is a long time ago that we developed this APOL1 gene. Well, that APOL1 gene, however, it is an adaptive response that keeps us from having severe spirochetal infection, increases our risk of kidney disease and the severity. So we do have a genetic predisposition.
Understood. And the very last question, doctor, is, are there any natural herbs? Now, this is bowling down my alley. Are there any natural herbs or supplements to help reduce blood sugar and or hypertension?
So yeah, there are. And ironically or unironically, kidney disease is one where there has been a little bit more open-mindedness in the typical allopathic community when it comes to natural herbs and substances. There's been great acceptance of like St. John's wort and saw palmetto for obstructive neuropathy. But, dandelion root to serve as a diuretic, that's risky because that can interact with other medications, not necessarily just cause kidney decline, but it can interact with other medications and thereby lessen their efficacy. I will say there are a host of diseases that we typically don't see in the United States that are attributed to herbal medications. Glyceric acid is one from herbal remedies, right? Herbal teas. And that will cause acute interstitial nephritis. So that actually can cause kidney damage. So we do have to be mindful of what we put on our bodies. It doesn't matter if the FDA approves it or not.
Understood. Thank you very much. There are no further questions.
Okay.
Dr. Buford, I want to thank you from the bottom of my heart. This is an issue near and dear to me. Again, suffering from low creatinine levels. Thank you for your time and the information. To the participants, to the participants, thank you so much for giving us an hour of your time this Sunday. Stay tuned for more awareness summits to come in the future. We thank you very much. And with that, we bid you all a good night.
Thank you.
Good night. Thank you, doctor.
Thank you.
Thank you.
Appreciate it.
Thank you.
Thank you.
Thank you.